Hello, and welcome to the latest edition of Health on the Line, produced by Health Comms Plus on behalf of the NHS Confederation. Before we get into today's episode, I want to mention a special webinar I'm hosting with NHS England Chair Penny Dash on the 20th of August. We're bringing together a panel of experts involved in developing the 10-year plan and who are responsible for its implementation to focus on how these changes, the changes in that plan, can be made in a way that empowers leaders and the broader health and care system. So if you're interested in that event, we're really getting into the nuts and bolts now, aren't we, of how we make this 10-year plan a reality. Please go to our website, www.nhsconfed.org, and the events section in particular to book your place. This webinar, by the way, has been funded through sponsorship by Boehringer Ingelheim Limited, and I should also emphasize that Boehringer Ingelheim Limited has no influence on the content of the program. Before we get into our main topic today, I want to bring in my colleague from the Confed, Annie Bliss. I want to talk to Annie because one of the kind of issues that's really a lot of importance to our members we're finding as we go out and we talk to them as we do on a daily basis is kind of performance oversight, and particularly league tables, which maybe Annie can tell me, but I'm not imminent, I think, but I don't know quite how imminent. So, Annie, welcome to Health on the Line. Tell us first about what you know about the government's plans to publish league tables, and can you tell me more about the date, which seems to be shifting around all the time?
Absolutely. So we first heard about the reintroduction of league tables back in November, and then with the 10-year health plan positioning kind of easy to understand rankings as part of its plans to improve public transparency, voice and choice. So I think really the intention behind the league tables is firstly to increase public transparency, which was announced in the plan and a big focus there. But a secondary aim is also to tackle underperformance and make sure that no more rewarding of failure. So that was something that was announced at the NHS Providers Conference. I think it's important just to make the point that, league tables are part of a wider oversight and regulatory landscape, and see oversight and regulation play an important role in making sure that you can identify providers that are in need of support, ideally get ahead of the issues that are going to lead to poor performance and potentially safety issues. So it's really important that is tackled in a robust way. Publishing performance data in the form of league tables is kind of one tool within the context of performance management. And so that tends to focus more on immediate issues like operational and financial performance. So it's really important that they look at the right things. In terms of timescales, we're expecting the league tables to be published in the summer, so most likely in September. We know that they'll cover acute mental health, community and ambulance trusts, and it will be linked to the recently published NHS Oversight Framework, which has a shortened set of metrics to support rapid recovery.
So, I mean, my view, and I find the debate about league tables fascinating because I've been looking at these kinds of ideas and debates for 3 decades as I've thought about kind of public service reform and innovation. So the arguments are kind of well rehearsed. I mean, I guess my starting point on this is they are simply inevitable. In fact, I was reading the Yorkshire Post the other day, or the York Evening Post. That's just the paper for York, and it had an article saying best and worst GPs in York according to our readers. So the fact is, people are able to generate all sorts of league tables. HSJ, and week never passes without them publishing some kind of list that tells you who's the best and the worst. So for me, the starting point is that this is inevitable. The question is not whether there will be league tables, and equally, if you're doing well in a league table, people will assume you're a good leader. And if you're doing really badly, people will assume you're not such a great leader. So it's kind of defying gravity to suggest that you kind of don't do this. But then equally, on the other hand, the gap between doing it well and doing it badly, doing it in a way that improves things for patients and doing it in ways which can actually kind of lead to perverse outcomes, that gap is huge. So it's not whether you do it, it's how you do it. So Annie, tell us a bit about the conference perspective on some of the key things we need to make sure we get right.
Absolutely agree, Matthew. So I think giving league tables the best possible chance of achieving, what they're setting out to do. So encouraging some healthy competition, increasing local accountability, sharpening the focus on national priorities. The way we do that is to kind of make sure that they're not set up in a way that is intended to kind of just name and shame. They need to be designed thoughtfully. Um, I think it really, obviously, it matters what metrics you use, what behaviors you're incentivizing, what data is available to support that judgment, how the information is presented as well. So it's absolutely, how do you take forward this approach? So, for example, while it's important to have clear rewards for good performance and clear consequences for underperformance, this needs to exist alongside a program of support which is tailored to organizations that are struggling and who might lack the capability to drive improvements on their own. So I think for us, we probably have some sort of considerations around whether that is being taken forward in the most appropriate way. So, do the ratings provide a rounded and accurate view of organizational performance? Is it clear and transparent to the public exactly what they will and won't do? And also, how do we look at past examples of league tables? So we've done this before, but actually, what metrics give us the most meaningful measures? What metrics can we look at from outside the UK? And how do we mitigate some of those unintended consequences, perverse incentives?
And I mean, Annie, I could talk to you for hours on this, but we've only got 2 more minutes. But one other concern I have, which you didn't mention, is, if neighbourhood health is going to work, if the left shift is going to take place, we are going to need organisations to work effectively together in the interests of the public. Is there a danger around league tables that they reassert the importance of organisational performance and they miss out the importance of integration and collaboration between organisations?
I think that's certainly a risk, and obviously the league table approach needs to align with some of the other levers for change that were in the plan. So financial flows, the national target, some of the things you've mentioned there. And in particular, there's a drive towards a more devolved model based on earned autonomy. So how do we make sure it kind of aligns with some of that? I think the most important thing really is that they do improve public transparency, and that they're also going to actually empower the public within the context of a wider set of measures to increase their agency and choice over their own health. I think that's one of the key things that we know the 10-year plan needs to do. So how do we make sure that the information is communicated in a way that makes sense, that's understandable to the public? And also, how do we make sure that the metrics are things that do matter to most of the public? So obviously, it might be a reach to suggest that publishing a league table may change someone's choice if there is actually no choice in reality about what services people can use. So I think it's important that that communication is clear around what they can and can't do. I think there's some considerations in terms of financial override, which sits within the oversight framework, and whether, how much that can be a consideration for the public in terms of what services they use. As a member of the public, I don't necessarily care if the trust that I'm using is in financial deficit, but I do care if they're going to deliver high quality care for me or for my family members, for example.
Yes, well, I think that's a good point to end on it, because I think eh, a bit of advice I would give to all policymakers is the more things you try to achieve with something, the less likely you are to succeed. And so if you've got league tables and you're trying to improve performance, you're trying to increase transparency, you're trying to inform the public, well, fine, but those things might pull in different directions. So it's better to do a couple of things and do them properly than try to do too much and end up with something which in the end doesn't do anything properly. So a lot of work to be done. We're working closely with officials at the centre to try to help them to get it right. I think it's right, isn't it, Annie, to say this first iteration will very much be a first iteration, and these league tables will develop over time.
Absolutely.
Thanks, Annie, so much for joining me. As regular listeners to Health on the Line know, we're in the process over a number of programs of talking about the implementation, the implications, the opportunities, the challenges of the 10-year plan. We've talked about that in relation to mental health. We'll be talking about it soon in relation to neighborhoods. But today, we're focusing particularly on technology, on data, on AI, on digital. So much ambition in the plan, so much possibility of change. But then, well, so much scar tissue in the NHS in terms of how we've tried to get this stuff right in the past and we haven't succeeded. Well, with me to talk through all of this, I'm delighted to have Dr. Nnenna Osuji, who's CEO of North Middlesex Hospital, and Andrea Winders, who's Head of Business Development for MIDAS, which is the Inward Investment Promotion Agency for Greater Manchester. Welcome both to Health on the Line.
Thank you.
Hello.
Now, I know you both took part in sessions at our recent Confed Expo conference in Manchester, looking at how the NHS can better use data, how it uses AI, how we achieve the third of the three shifts that Wes Treating has been talking about, and which still run through that the 10-year plan. So the 10-year plan, never short of hyperbole, says the ambition is to create the most digitally accessible health system in the world. Now, I'm just going to recap for our listeners the kind of key elements of that. That's establishing the NHS App as the front door for all healthcare services, the doctor in my pocket principle, wanting to allow anyone with an NHS number to access their health data via a single patient record so they can self-manage their own care and ultimately live healthier lives. And then there's lots of ambition around AI, including the development of a strategic AI roadmap with clear ethical and governance frameworks alongside staff training. So there's a huge amount in this. We know that Wes Treating is a great enthusiast for the possibilities for technological transformation. So I'll just start, both of you, with a kind of big question. I'm going to ask you to kind of give me a kind of a headline answer to that, which is, now you've digested the 10-year plan, in a sentence, Nnenna, I'll start with you. Does it feel like it's pointing us in the right direction for where the NHS needs to be in the next decade?
Thanks. And I'm focusing my answer mainly on digital. And we know that the status quo is not sustainable. I love the commitment to bring digital currency into health, which feels the right direction of travel. Of course, the devil is in the delivery and how it's translated with people, by people, for people. But in terms of ambition, definitely the right direction.
Andrea, what's your view?
Yeah, I'm pretty similar. I think the ambition is there. I wish it had gone a little bit further, if I'm really honest. I'm a disruptor, so I really want to see this being a little bit more disruptive. I wish it contained more around the culture within the NHS and hadn't generalised as much as it has done, because then we'll know that every trust is different, and people is what makes the NHS tick and work. So I think it's a really great start. It's really ambitious, but I would question the deliverability, and I wished it would gone a bit further.
Well, let's get into that. So Nnenna, if I can start with you, in your experience as a clinician overseeing a trust, you've got a really great sense of where the tech is working, and but where it isn't, what the barriers are. So let's start with that barriers question first. What continue to be the biggest barriers to us exploiting the full potential? You wanted to focus particularly on digital.
Gosh, so I thought I'd be very careful with my answer here. I want to celebrate all that is good about the organization I work for, but I want to recognize some of the limitations as well of the systems in which we work. So we're HIMSS level 5, so we're not digitally naive in terms of our service. We've got an electronic health record, and we're an integrated organization, so we've got community services. If I were to ask, where we would want to go, I would want greater interconnectivity, both vertically and horizontally. So when I say vertically, I mean in place, so that when we talk about patients, we talk with the full purview of their health and social care in order to make better informed decisions with patients and with populations. I love the fact that the NHS app looks like a single source of entry, a single portal for engagement of people. I'm really conscious that 60% of our staff in this organization come from our local population. And I know it's beholden upon us as leaders to then think about, well, how do we train our own staff to make sure they're first conversant and also then sharing that opportunity? Staff will say infrastructure. So we want to talk about, new, exciting technologies and innovation. But actually, there's something about making sure before we go for clicks rather than bricks, that we get the bricks that we need for the clicks in place. And so simple things like Wi-Fi connectivity, making sure it's robust throughout the whole of the estate and in the community settings in which we work. Elements around, not looking at that circle of doom on a computer, you know that when you buy any form of technology, the second you walk out of the shop, it is already almost out of date. So how do we maintain the currency of the hardware and software that we supply our staff with to make it work? Longer term, I'm thinking about environmental sustainability, and not just the hardware and software, but also some of the digital space in which this would be secured, and the cybersecurity element of this, which is something that we're more and more current, more and more concerned about. So we've had examples of where that can go differently. If I pick up two small other bits, there's something about how we get the basics right. So the NHS number as a single unique identifier is absolutely the right standard. And we know that with all our data solutions, what we put in is what we get out. I'm not sure that we are yet at a point as a system, as an ecosystem, to have our NHS number, our wristbands, our standards of our data in such a way that we can actually use it, harness it, and test it in the way we need to make digital solutions as effective as they possibly could be. So on the way, more to do around interconnectivity, both vertically and horizontally, a recognition of infrastructure. And infrastructure is not just the tech, there's also something about the people. I want to make sure we have the subject matter expertise, and that's a level of expertise that is few and far between, that our staff, we have some who are fearful, some who are fearless. How do we make sure we have the training to bring everyone on the same journey? So more for us to do for sure.
I noticed, I think yesterday, NHSE published data, I might be in the department, about the fact that there had been quite a significant uptick in the use of digital virtual appointments in primary care. That obviously it went up a lot in COVID, and then there was kind of questioning of it, and then there was some unhelpful political interventions. And it fell back again. But now it seems to be picking up, and maybe picking up more organically, simply because it's what patients want, and it's the best way in which the health service can offer access. Where do you think we are in terms of that kind of story of digital digital access to the health service? Because it has been a debate that's gone. It's been a kind of like a lot of technology debates, really. We've had these kind of moments of exuberance and then disillusionment. Where do you think we are, and where do you think we need to get to?
So I think it's part of a solution, but it's not the entirety of the solution. And digital is meant to augment, not replace what we do. It's difficult to make a blanket statement because I think there are different populations who engage in different ways. And some of that is about language, some of that is about understanding, some of that is about age. So 0 to 5s, for example, tend to want to have their parents, of course, more face-to-face than necessarily virtual consultation. But I think we need to recognize that there is a demand out there for people who are as young as I am and younger, who want to have the immediacy and the asynchronicity of a virtual contact, who want to have convenient healthcare, and that there's a cohort of patients where we look at things slightly differently, where we look at transactions of care, that sort of quick fix opportunity that doesn't necessarily need to take up time. And by using virtual mechanisms and remote mechanisms, we then free up time for people who do require a little bit more complex. I would always say, as a clinician, there is no substitute for hands-on. And sometimes in a moment of a consultation, you pick up something that you might otherwise not pick up. And so when we were looking at virtual solutions, even as simple as virtual clinics, it wasn't an either or, it was an and. So we would, for example, have patients come for 2 virtual clinics, but the third clinic had to be face-to-face. So it's how we use the fullness of the offer to make sure we respond to what people need, respond to what people want, and maximize the opportunity for us to do more for the most. Gosh, it's a big question, and an important question, and one in which we're actually living the reality of that question. I am an AI advocate. I think you have to hold me back a bit in most cases, but I think that diametric position between speed and control is one that we're living in. Many people want to almost close the gate, but actually the horse has bolted on AI. AI is permissive, it's everywhere in our lives, and so many people are engaging with it. I think that the way we engage with it is different. And we need to recognize that. And I'm really aware of the potential impact on people. So people who are operating at the top of their license can use AI in ways that actually help to augment and release more time to care, and can look at productivity, can question and test AI and use it as a starting point, but not the end point of the product. And I think that's really important, because we always want the principle of human oversight on AI, even if it's not humans doing every aspect of the task. The second bit for me is that AI is absolutely necessary. And I say that because of the volume of data that is becoming normal in providing care. That's personalized data if we look at things like genomics. That's population data. If we look at the size of the populations that we're responsible for, there's no way we can use human capacity alone in order to mine that data and provide the insights to make either personalized or population-based solutions. So we absolutely need to use AI. The question is how we balance that governance and that speed in a way that allows us to move forward. And there is something about the way we look at governance, which often looks at tangible products versus concepts. And I think we need to look at AI as conceptual governance and think about the way we manage that ethically, but realistically, so that we have sufficient speed, but sufficient caution. I am
Thanks, go on.
No, I'm really clear as well that in terms of moving forward with AI, there's something about the parochial. We spoke about the bricks for the clicks, but also the standards that are really, really important. We spoke about cybersecurity. I just don't ever want to let that go. So there's a parallel expectation as we move forward. And of course, from a commissioning point of view, we need to think about if we're replacing hardware from a capital point of view and the revenue implication. So what is the commissioning landscape in which we do this? Lastly, I really want to highlight people, both in terms of subject matter expertise, both in terms of our staff who need to engage with this in a different way, but also in terms of how we design equity by intention in what we do. We know many examples of where we've used AI and the inputs have been themselves skewed so that the outputs actually can potentially exacerbate inequalities rather than diminish that. So there's something about how we ensure parity in design and parity in the way we manage and monitor some of the AI outputs.
Thanks, Nnenna. And Andrea, I've got questions for you, but actually, I'm first just interested in any response you've got to what you heard from Nnenna.
I'm fascinated by Nnenna's response, and really pleased to hear that she's an AI advocate, because I travel the world quite a lot, and I see some great innovations that use AI to help clinicians or to help non-clinical staff like pharmacists. For example, I've seen the AI stethoscope, which could be developed and be present in pharmacies, so that if somebody goes in with an issue and the pharmacist isn't an expert, they've got a certain degree of knowledge, the AI stethoscope can step in and maybe help to either alleviate the concerns of the person, or to help them to know when to refer forward. I've seen it being used in things like circulating tumor cells scans to speed up that process and to help the human eye to pick out issues. So I too am a strong advocate of AI and technology, but I carry the same concerns about making sure that everywhere's protected. In the past, I worked in smart cities and I saw what a data breach can do, or a cybersecurity attack could do to a whole town. And it could be such a simple attack that happens within a hospital, even down to a fish tank, dare I say, that there isn't necessarily a piece of clinical equipment that could cause major issues that has ramifications beyond what we know. And I think the NHS has got lots of opportunity to adopt and adapt AI and other technologies, and maybe something as simple as business process management to connect systems so they talk to one another. There's a lot that can be done.
But Andrea, you go around the world. You have a background in innovation. I guess the question I want to ask is, why is it so bloody difficult? Why does the NHS seem to make such heavy weather of these changes? You know, I mean, obviously it didn't happen overnight. It took 10, 15 years, but you know, overwhelmingly people are online banking and accepting that's what they have to do and accepting responsibility for their part in making that kind of interaction work. What's your sense of why this is so tough with the
So
NHS?
this is an outside point of view. You know, I'm not working within a hospital, so don't, please, Nana, if I say anything that's insults, do not take it to heart. I think it's just so difficult. It's a large ship, a large tanker, very difficult to turn. And as I said earlier, people are at the heart of the NHS. People are what makes it tick. And I think it's getting, it's managing that change, because you've got I actually broke down the change bell curve earlier. It's managing that change that's difficult. I think there's the will to adopt and adapt new technology and new influences, but the actual practical way of doing it is just tremendously difficult. And it's also, who owns the data? I have conversations with the ICB, with the Health Innovation Network, and others who say, oh, we own the data. And actually, no, you don't. I own my data, and it's my data. I think there's a change of mindset needed about data and accessing data and how we manage that, to put the citizen at the center as a starting point rather as the end point. I love tech. I don't use the NHS app. I'm sorry. I don't use the NHS app. And I've given up trying to use it with my GP practice, because it's just so difficult. So I think we've got some learning to do. But if you get
That's a sobering thought, Nino.
It really is, actually. I was just sitting here thinking that that's a shame. So I would give examples of the NHS app where in clinical practice, someone comes to see me and is able to share the trend of their results, so that when I see them in that one consultation, I can give an opinion with them, explain to them, they feel reassured and they can walk away. So I think the power of the app is there for sure. I love the fact that it is a patient-owned element, and that we start the conversation, as you say, with the citizen, with the person. And I think that's going to change the way people engage with their healthcare. It's also going to probably protract some of our conversations before they compress the conversations, because people start looking at every facet and become more curious. But I do think it is a way, I think your challenge, Andrea, to how we make it more user-friendly, how we make it interface with other elements. So we talk about my choices, we talk about my care. I think there's a lot that we can do in that. And within that provision, something about how we make sure we speak all the right languages. And I don't just mean whether you speak English or not English. I mean whether you speak medicine or not medicine, whether you speak NHS or not NHS, and how we actually use it as a navigation tool as well. I am hearing you say there's more we need to do to make it something that is more user-friendly, but the power and the patient and person-centric nature of what it can deliver is huge.
I'm going to come back to you both with a kind of hypothesis about why this is difficult, which is not a kind of, by the way, to say we should abandon hope. It is to say that we just need to understand and hold that difficulty. But just before I do that, Andrea, another kind of question for you when you're thinking about the work that you're doing with innovators and life sciences. I have to say that I think part of the problem in the NHS is that we have been fairly consistently sold things by the commercial sector with claims made which then are not fulfilled. And I'm not saying this is deliberate, that people mislead us, but obviously if you're selling a product, you'll sell the product with the full potential that you think that it's got, but you may underestimate the degree of time it'll take for it to start to pay off, the cultural changes that are required for it to work, how other things have to work together. It is part of how we do technology innovation better, a better quality of relationship between the health service and commercial partners.
I think that there needs to be a better relationship, full stop, between commercial partners and the health service. Almost every day, I have somebody trying to sell to the NHS, saying we want to land in Manchester and we want to sell to the NHS. And my message to them is stop. Don't think like that. I'm working with, it's Manchester Foundation Trust here in Manchester. I'm working with primarily, and their innovation team. And I put a challenge out as to take a different approach to innovation, how we can actually start with a problem
So as opposed to having the door open to everybody and anybody coming in and trying to, if I get told about a mental health app again, I must see 2 a day. It's look at what the problem is, not what the solution is. So I'm challenging MFT to come up with problems, not solutions, so that then we can maybe do call outs to businesses to work globally to get solutions to come in. So flipping the lid on that, Matthew, so that the NHS isn't being sold to, is having a problem resolved. I'm hoping that that's the way forwards. Because like I say, I see so many, and every entrepreneur, every innovator obviously thinks that theirs is the best product ever. Large pharma invests hundreds of millions of pounds in creating new solutions for drugs. We're not seeing that in digital. We're seeing the one-man bands. We're seeing the smaller companies coming up with innovations. So I think there's just a different way of approaching this that could improve outcomes for the NHS, but also could improve success for entrepreneurs. I see something great in Leeds. Actually, Leeds Teaching Hospital has an innovation. I don't know what they're calling it. I wouldn't call it clinic, but that's not what they call it. But that is kind of do what we're talking about. They've got a problem statement. They invite entrepreneurs in. They've got a space called Nexus, which is a startup space. And then they've got the Health Innovation Network who help those entrepreneurs to get ready. I think we need to start thinking differently like that. And it's to stop people selling to the NHS per se and start from the other way around.
No, well, I absolutely, I completely agree with that. In fact, I remember years and years ago, Hackney Council had exactly that approach, which is to pull it's easy in Hackney, there's a lot of entrepreneurs, but bringing their entrepreneurs in and start with defining the problem and telling them to go away and come up with a solution, because so often commercial companies have a solution looking for a problem. Nnenna, for you as a leader, you have commercial partners knocking on your door every day saying, look, here's a solution to all your problems. What do you need different kinds of support, better support in terms of helping you to make the right commercial decisions?
So I love the way Andrea has framed that. I think that often we have solutions that are sold to us, and they're solutions looking for problems rather than problems in search of a solution. And I think that's exactly where we need to be. I think the second bit for me is around, we talk about innovation as though it's always something new and bright and shiny. Sometimes innovation is adoption. How do we make sure some of the simple things that work well, that are digitally based, and I would use Scan for Safety as a really good example. You spoke about Leeds, North Tees, and others have used this. How do we use the things that work well and ensure we scale them up? So to your question, Matthew, there's something about how we avoid that sort of pilot paralysis that besets us in the NHS. I don't need to pilot it on behalf of someone else who has piloted it elsewhere, particularly for something like AI, where you know that the user case is well tested, and all we're really doing is making sure we understand how it enters the organization. So I think there's something about what is the footprint of a pilot that allows us to adopt it, but also what are the specifications and how can we agree those regionally or nationally so that we're looking at the same thing rather than each person losing time, money, productivity, and cognitive efforts, trying to find bespoke solutions for small problems. Look, rather than saying this works, let's adopt this.
Yeah, and there is, to be fair, some specific recommendations in the 10-year plan, particularly in some of those areas around kind of, once a technology is proven, that it should be much easier for other people to adopt it. Let's go back to this question of why it's so difficult, though, and suggest a proposition to you, starting with you, Andrea, which is that in a way that the way that technological innovation takes place in the commercial sector is that there's a kind of letting go of control. There's a kind of willingness for people to test things out. There's a kind of, fake it till you make it kind of culture, which has got all sorts of problems associated with it, but is in the end a thing that does create an environment where all sorts of innovation flourishes. And also, in the commercial sector, if you're a commercial organization, you don't have to provide a solution that works for everybody. You've just got to provide a solution that works for sufficient customers, and then you can refine it and try and bring in more customers. In the health service, neither of these things apply. We can't have a kind of fake it till you make it culture. And as Nnenna has emphasized, we need solutions which work for everybody because we're a universal service. So I guess the first part of my question is that right? Is that one of the things that makes this so difficult. And if that is right, is part of what we have to do to be a little bit more willing to accept risk, and also be a little bit more willing in a transitional period to accept that sometimes there'll be solutions that won't work for everybody, but they'll work for some people, and then over time we can develop them so that they work for more people. Is that the kind of change of thinking that we need? Andrea, I'll start with you.
Yeah, absolutely. That's the kind of thinking that we need to change. And part of the problem comes from all the different trusts. So that within Manchester, we've got 5 trusts alone. So it wouldn't necessarily follow that if one trust took on a digital product, that another one in even the same region would take it on. So I think that's part of the challenge. And it's back to that pilot. I think somebody within our Health Innovation Network said we've got more pilots than BA. In our NHS, and it's part of that approach. It's like trust it. So I'm not an expert on procurement, but maybe that's back to procurement as well. And we're dealing with people's lives. So the fear is that if something doesn't work, we've got a person's life or wellness at the heart of it. But that's where AI can come in and predictive modeling. So we can actually start machine learning, and AI can actually help us to determine how best to use products, so that we can get the better outcomes, and that we can accept some minor failures, or we can then target that product better because we've learned how it works. So I think we've got quite a lot of learning to do in the NHS or in the health services to pick up on that. I mean, one example I could give from another industry is maybe the car industry. So I worked in Sunderland for a number of years and worked with Nissan, and I saw them change from when they landed in 1975. I wasn't working there then, but in 1975, when they had a production facility, but they've adopted robotics, they've adopted AI, they've adopted machine learning. They operate a just-in-time system with all their suppliers, so that they're not holding stock, and that now means they get 2 cars off the production line every minute, and it's. What they've done is they've learned and adapted. Now, slightly more difficult than the NHS, but you're absolutely right. That's what we need to do, is to adapt, and learn, and move on, and have a system where, if it's accepted in the NHS in one hospital, it works. Don't pilot again. You work with it.
Yeah. No, I think we can agree on that. And then, to what extent do you think our quite appropriate worries about risk and commitment to inclusion can sometimes get in the way of being more entrepreneurial in terms of technological development and innovation?
I mean, I think risk is a two-edged sword. We spend a lot of time thinking about the risk of the things that we know about and that are in front of us. I would say there's equally a risk about the things that we are not paying attention to. And that we need to think slightly differently about that. I think part of the reason, and we're all sort of once bitten, twice shy. We don't operate in a system that forgives risk or forgives failures in many ways. And the consequences of failures are quite extreme. We're talking about human life. So there's a good reason why people are cautious. But an abundance of caution can itself become a risk. And we need to be careful to find a balance. And I think this comes back to the principles of governance. So how is it we maintain human oversight? How do we test and have appropriate audit of things that are AI driven or digitally driven, so that we don't always release the reins completely? We maintain some element of scrutiny and oversight, and in all our thinking, first do no harm. But I do think there's something about how we adjust our risk appetite and how we think about the seen and the unseen elements of this. And I'd say lastly, I mean, when I use the word experimentation in the NHS, everyone looks at me with shock and horror. But there is something about how we experiment safely and how we just set the boundaries of what failure can be that is tolerated, and that we move forward from that. So I think that's a really delicate equation. It's one that we're grappling with. It's not an easy one, but it's an important one. I always remember a conversation around what if we get it wrong with AI as relates to populations. And I would say yes, but AI might allow us to identify a population that is not yet on our radar. And actually, what is their health impact? So there is something about us having to have a very different relationship with risk, but a bounded relationship, and one based on principles rather than product.
No, I think that's absolutely right. And I think the way we construct the narrative, with staff and with the public here is really important. So exactly as you say, Nnenna, on the one hand, when we talk about inclusion and technology, we can focus on the dangers of exclusion for people who, for example, don't have access to Wi-Fi or whatever. But we should also recognize that the technology offers enormous opportunities. I've seen this in mental health for us to provide services which people can access in new ways who would have found it difficult and have found it difficult accessing services in traditional ways. And equally, and this is a point that Joe Harrison from Milton Keynes, who's on the Confed board, often makes, whenever we talk about the risk of innovation, we should always start from recognizing the risk that exists in the current system. We're never introducing innovation into a risk-free system. We're changing the risk profile. Look, I want to end on a positive point with both of you. It's been a fantastic conversation, and that's just what ultimately, Nnenna, I'll start with you. What do you think is the biggest game changer here of all? I mean, I think when I look at the 10-year, I'll answer my own question. I think individually owned personal health record, the idea that we all own our own data, I do think that could be an absolute game changer. But Nnenna, what for you is the single biggest game changer here?
I like the question. I'm with you in terms of patient ownership, and I'm going to use up data and insights that we can use to provoke change, to represent both parity, personalization, population health, and a future-proofed health and care system. That, for me, is the game changer.
Andrea?
Do you know what? We're actually, I talked to you off air, Nnenna, about this if you're interested. We're doing having a project in Manchester where we're actually bringing in a wellness wallet. So I'm with you as well on that one. So it's using data from all your wearables, connecting together, not replacing the NHS app, but coming from a different angle completely, and with wellness at the heart. So I'm really excited about the prevention rather than cure. I've seen it in action in France. I went to France recently. Spoke to somebody who'd moved there from the UK. They'd had a heart problem in the UK and had a couple of stents fitted. When they went to their clinician in France, they had more stents fitted because they said this is, and he asked the question, why? So, well, this is prevention. The others were curing your issue. This is preventing. And I love the fact that we're going to start changing our mindset around that.
Well, look, who knows, Andrea, and then if you work together on a wellness wallet or anything else, Health on the Line will have fulfilled its potential, not just to engage and entertain people, but to be the basis of a new innovation. Thank you both so much for sharing your thoughts with us today. And as I say, listeners, do keep an eye on our website where we'll be posting lots of opportunities for members to get involved in discussions about how we make this plan a reality. Thank you both.
Thank you.
Thank you.
Bye-bye.
You've been listening to Health on the Line, produced by Health Comms Plus. Health Comms Plus is a highly effective, innovative and creative communications agency brought to you by the NHS Confederation. We offer a creative, professional and cost-effective service for NHS and public sector organisations across the UK. Any profit we make is reinvested in the support we provide to NHS organisations and wider health and care systems.